told you about the main problems with these valves. Are we talking about when I say mitral valve or if I say aortic valve? What side of the heart are those on?
Left.
Left. So the two divisions are problems that we see with these valves on the left side of the heart. Stenosis, where is what? Narrowed. So if a valve is narrowed, the hole, can sufficient amount of blood pump out?
No.
Okay, and the left side of the heart pumps to the
Lungs.
the
body. LB.
All right, I know where you're going. I just see it if y'all are still with me. Hang on, we're going to get it together. All right, but I get where you're going. Hang with me. All right, everybody come back. Come back. All right, we're going to take the blood. All right, we're going to take the blood flow. Left atria. Then we got a valve between the left atria and the left ventricle called the mitral valve. Y'all remember that one?
Yes.
Okay. Then the blood is in the left ventricle, the big dog. Remember the big dog? He does all the work.
Yes.
And the left ventricle has to pump out through which valve?
The pulmonary.
The aortic valve. So does it make...
Let's get along.
Who said it wrong?
We just need a picture of the heart up there.
No,
Right.
you're not going to have a picture of the heart on your test.
Oh my God.
So in your brain, come on now, in your brain. Left side of the heart does the most work. All right? Which means it has to pump out to your entire body and serve all your major organs and keep them alive. So if your left ventricle does the most work, then it has to create the most pressure. So the left ventricle, when it's pushing out through that aortic valve, that's probably the highest pressure that there is. Okay? So I want you to think about that when you think about the valve that is most replaced, that we have the most trouble with as we age, is the aortic valve. Because that is the highest pressure valve that you have in your heart. Because it's having to push out to the entire system. Now remember, we talked about something called afterload when we first started, didn't we? And afterload is that pressure or resistance that the heart has to push out against. Do y'all remember that?
Yes.
So what about the patient who has hypertension and that high pressure out in the system or your tank? All those vessels of the tank. You know how you put a cup on somebody's arm and their pressure's like 200 over 110? Is that high pressure?
Yeah.
And so remember, some of the treatments that we give for high blood pressure causes vasodilation. And what we're trying to do is open up those vessels, widen them out to bring the pressure down. Okay? So if the poor aortic valve and the left ventricle is like, oh, got to get out to that high pressure system, are you working that left ventricle hard? Is there a lot of pressure there at that aortic valve? So when you're reading, it's going to tell you when it starts talking about aortic valve disorders, it's going to say that the aortic valve, the problem is wear and tear on that aortic valve as you age. And it is for that very reason. So one of the problems with the aortic valve is this problem occurs over time. And if you're old, forgive me for just using that term, if you're older, then you probably have a lot of different disease processes going on, because we're all like cars, just face it. Everything kind of, honestly, as you age, things get wear on them. And so the problem with aortic valves is that when they're needing replacing, the patient has to be in a condition that they can tolerate an open heart surgery. So I know, I can think in my mind of several people that I know that would not be a candidate for this because they couldn't withstand a major surgery. So these patients, we have to recognize this problem pretty early and try to get them to have this valve replaced because no surgeon's going to touch them if they're going to die on the table. So that is why they have created other procedures to help patients who have things like aortic stenosis. If there's any way possible, instead of taking this patient to surgery and having an open heart surgery where they repair the valve or replace the valve, maybe I could bring them to the cath lab. And I can thread a balloon up through their aortic valve and open it up and get them more blood flow through it. Would that not be the better way to go? Remember, the problem with that is it only lasts because your valves have memory. And so they're going to kind of contract back down over about 6 months. But could this be a possible procedure that patient could come in every 6 months or yearly to have done, and they can tolerate it? So there are other procedures you're going to read about in your book when you're talking about aortic valves. But what side of the heart are these valves on? Left side. So we see more problems, and I'm not saying that we don't ever replace the tricuspid valve or we don't ever do reparative procedures on the right side of the heart, because we do. But it's not common, because typically, which side's going to do the most work? The left side. So that is why in this classroom and for NCLEX, what do we cover? Mitral valve, stenosis and regurg, and aortic stenosis and regurg. What does stenosis mean? Narrowing. And now, just because a valve is a little bit narrow doesn't mean they're going to risk taking them to surgery, crack their chest open, and fix it. I want you to know that. But when the opening of a valve gets about 1 centimeter or less, we got a huge problem. Because can a sufficient amount of blood get out of that valve into the system if it's that small of a hole? No. What's going to happen if you increase the demand on the heart? Can they pump out of that hole what you need? No. So, again, this patient is going to be that patient that starts becoming very symptomatic if you're pushing them in physical therapy. This will be the patient that dies during a stress test if we did not know that. Okay? So that is the very reason that we like to do an echocardiogram before we send them for stress tests. It's non-invasive, and we can see the size, shape, structure, how the valves move, and all that. Does that make sense? We can see if that valve is narrowed or if that valve is very floppy. So, all right. So we're talking about valve problems on the left side of the heart. On the board, we had written earlier that there was a table in your book. And in the other class, they wrote like AS, which means aortic stenosis. And then they wrote MVP, mitral valve prolapse. And then they wrote mitral stenosis, MS. And then they wrote MR, mitral regurg, just like the table. But instead of putting all the common things, they put the 1 or 2 things that were different about each one. You don't have to memorize all the different types of murmurs, but I want you to understand that a patient with any of these problems, whether it's narrowed, which means stenosis, or regurgitative, which means floppy, okay, it's not closing, they're going to have a murmur. Are you, as the new nurse, going to say, oh, that's a decrescendo murmur? I'm excited when you go, Miss Cooper, I think I hear a murmur. I'm like, do you? Oh, my God, how awesome. Let me go see it. And then I'm like, that ain't no murmur. I'm kidding. But I get excited. Just remember, anytime you have turbulent blood flow, you're going to hear what in the heart? A murmur. So the common thing, if you look across that table, is signs and symptoms of left-sided heart failure, because these valves are located where? On the left side. Okay, so if I got this little bitty hole, and I'm trying to push blood through it, and it's all not going, where's that blood going to go? back up. Into where? Oh, thank God. Okay. Woo, I'm sweating. Okay. So if you look across that table, you don't have to memorize all that because they all have got signs and symptoms of what? Right, that's correct. So now, if you plan to work where they repair or replace valves, you probably do want to know all those little specific nitpicky things that are different, okay? So mitral valve prolapse, my family typically has that, but I don't, thank God. So I got a sister that has it. But I can't hear a darn thing when I listen to her heart. But if they have a significant prolapse where that valve, they have a valve leaflet that just kind of flaps back, okay? It's not significant enough to call it regurg because it just kind of flaps like that. If it's significant, sometimes if you listen in the mitral area where you listen for an apical pulse, do y'all remember where that is? Lift the left boobie and stick your No, really, where is it? Hallelujah. Then you might, when somebody has mitral valve prolapse, you might hear a click. Are you with me? A click. Not always. Not always. Now, if mitral valve prolapse becomes significant, then they classify it as mitral valve regurgitation. And that is why I try to tell you which one do I want you to learn. I want you to learn mitral stenosis and mitral regurgitation. You can learn a little bit about prolapse and won't hurt you, okay? But they're not going to hospitalize somebody for mitral valve prolapse, okay? But you will see them at the clinic with mitral valve prolapse talking about, I have some palpitations and I have this atypical chest pain, and they'll say it makes them have high anxiety. But what's your focus for me? Stenosis and regurgitation. All right. So do you need to visit that table in your book that tells you all the signs and symptoms?
Yes.
Yes. Do you need to know they're all what the common theme is? And are all going to have a what? Murmur. Except for mitral valve prolapse, they're going to have a click. Very good. All right. So, with any of them, or if I told you we're having signs and symptoms of left-sided heart failure, are we going to have decreased cardiac output?
Yes.
All the ones I told you to learn. Yes. 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 So tell me some of the signs and symptoms of decreased cardiac output.
Shortness of breath. Dizziness. Decreased LOC.
All right, good. Y'all learned. So mitral valve prolapse, look and read so you'll be familiar with it. Sometimes they're totally symptomatic. And then as it gets a little bit more significant, these are some of the things they're going to complain of. And so we're going to do an echocardiogram to classify how bad it is. They'll do it in percentages. And then how are they going to manage it? Well, they told my sister years ago to stop taking some drug called Fen-Phen. Y'all even remember that was a diet drug out? Yeah. And one of the things it caused was it worsened or caused mitral valve prolapse. And my sister loves to be skinny and beautiful, so she'll do anything, whether it kills your heart or not. So anyway, she quit. She's fine. If her mitral valve prolapse gets worse and worse, they're going to classify it as mitral regurgitation. So what's the problem here? You tell me.
It's a floppy flap.
So do the leaflets close and ensure that the blood continues to move forward in the right way?
No.
And if it doesn't move forward, what does it do?
Backwards.
And sometimes patients have this and it's not so bad and it's chronic and they don't even know they have it. We just happen to find it. Interesting, huh? So acutely, this can occur after a bad heart attack where the valve was part of the damage. And so they're going to have horrible signs acutely of heart failure, left-sided heart failure. And so do you see those signs and symptoms up there? Dyspnea, cough, fatigue, weakness, shortness of breath on exertion is a huge one, isn't it, of left-sided heart failure. Do y'all see the picture that I was telling you about earlier? Of what? What's that picture of y'all?
TEE.
TEE. Is that important, and do you need to know about a TEE?
Yes.
What's the major safety with a TEE?
Gag reflex.
Very good, because if they numb the back of the throat, is that a problem?
Yes.
What if you go in there and their grandma brought them a cheeseburger?
You have to wait till after
Should
the
the patient
procedure.
know about that ahead of time?
Yes.
Where we're trying to go. Because can you be in your patient's room all the time?
No.
No. Some of the most horrible things that ever happened to me as a nurse was because I wish I'd have said something that I think I didn't have to say to a family. Something like insane, you know what I mean? Don't assume people know stuff. Do your teaching ahead of time in case you are not in that room when they return from that procedure, okay? All right. So again, how do we diagnose mitral regurg? Again, is this patient going to have a murmur?
Yes.
Yes. Is their pulse going to be irregular? You're going to hear that floppiness.
Yes.
If they have heart failure, you might hear an extra sound known as S3. Very good. And so, again, they're going to diagnose this with echo. Can a regular echo see the back of the heart?
No.
So we need what?
TEE.
Very good. So we're going to manage their heart failure. So here you go, looking at what are they going to medically do. So they're going to do afterload reduction with medicines. Is this patient going to need antibiotic prophylaxis for dental procedures and respiratory?
Yes.
For the rest of their life?
Yes.
Okay. And so if it gets extremely bad and they're a candidate, might they have a repair or a valvuloplasty? What is valvuloplasty?
Or a replacement.
So valvuloplasty, they may open their chest up and do what? Or they just go in there and repair their native valve. That's what that word means. It's a big umbrella term. They're going to do some procedure to work on repairing their own natural valve that they were born with. Does that make sense?
Yeah.
All right. Or a replacement. Now, stenosis means what? Okay. So now looking at that, if I can't get blood from my atria to my ventricle, where is it backing directly to?
The lungs.
So again, is this patient, if it's extreme, are they going to have some extreme forms of left-sided failure?
Yes.
Oh, yeah. And so, again, look at these signs and symptoms. If you've got a narrow mitral valve, do you remember the worst form of left-sided heart failure was called pulmonary edema? And one of the worst things you never want to see is your patient coughing up frothy, pink, red sputum, hemoptysis. Does that make sense?
Yes.
So if your mitral valve is occluded and all that fluid and your blood is backing up to your lungs, might they start having hemoptysis?
Yes.
Does that make sense? Do you see how you don't have to memorize all that table? Okay. And then wheezes, crackles probably, and palpitations. And so all that signs and symptoms of which side of heart failure?
Left.
Okay. And so all of these are going to have murmurs. If you can't push out a lot of blood out of your left side of your heart, is your pulse going to be weak?
Yes.
Yes. And if you are stretching your atria because you can't get the blood going forward, are you going to have some atrial dysrhythmia from all that irritation? Does that make sense to you all? Okay, do you see how you don't have to memorize if you can visualize? Okay. And then they might, a lot of times with any of these valve disorders, they'll do echo, but they'll also do a heart cath and take pressures and look inside the heart during a cath. They can look inside the heart. They can do biopsies of the heart. They can do all kinds of things during a heart cath. Okay, so we're going to treat heart failure. Do you think they're going to be at risk of blood clots? Yes. If you can't move blood forward, you're going to be at risk for blood clots. Right. And so, anyway, the valvuloplasty means
Replace the
repair the
valve.
valve, their native valve. Commissurotomy. Now I'm spitting. Do y'all remember the commissure is where the leaflets come together? So if it's a stenotic valve, what might they do? Clip them. Commissurotomy. Okay. And so, again, if we can't fix the valve, we might have to replace the valve. Do y'all remember the two replacements? Tissue and mechanical. All right, and tissue can be bovine, porcine, cadaver. Anyway, all right, keep going. Aortic regurg means the aortic valve is not being able to close, right?
Right.
So that blood's kind of trickling back. And if it's trickling back into the left ventricle. All right. So again, we got that problem, which is going to equate to left-sided heart failure. So look at the manifestations. Are they all left-sided heart failure right there? Dyspnea on exertion, fatigue on exertion. Is that? Am I lying to you?
No.
They gonna have a murmur?
Yes.
Okay. They gonna need antibiotic prophylaxis?
Yes.
Okay. They'll do all those tests. Do we need to push them?
No.
Don't push any of these valve patients, because if they don't have a lot of cardiac output, they'll kill over on you. Trust me, they'll have a bad dysrhythmia and die. Okay, so wear and tear, aortic stenosis, disease of wear and tear. Look at it up here. You got a normal valve, and that's how it's supposed to close. Look at the stenotic valve. Can it close right? If the hole's real small, it can't open either. Is that a problem? So here's your clinical manifestation. All left-sided heart failure. Might they have chest pain if they can't get blood out the heart? Now here you go. This almost makes me cry every time I tell it, so I'm not going to tell it much, because it's about time to go, ain't it? In a little while. I'll tell it quick. We had an old lady a couple of clinicals back who had pictures of the cutest little dogs you've ever seen. They were her husband's dogs. And her husband had died. And her husband made her promise that she would take care of those two dogs. This woman had aortic stenosis, and she had had it for a while. And they had told her that she needed her valve replaced. And you should do it before your ejection fraction. What's your ejection fraction?
The pressure.
It's the amount of blood that's pumped out of your left ventricle. And normal is like, in some books, 50 to 70. In some books, it's 55 to 70. Sometimes it's 50 to 80. It's according to what book you look at. But where I'm going with this is, they want to do valve replacements or big valve surgeries, open heart surgeries, when your ejection fraction is okay. Once your ejection fraction falls really low, like 30 or less, then you are not a surgical candidate, because you won't tolerate the procedure, okay? And so my student was taking care of this patient, and my student comes and gets me and said, "This lady is all upset." And I said, "Why is she upset?" She said, "Because the nurse told her that she probably wouldn't be able to get her surgery." This woman waited until these dogs died to get her surgery, because she had no other family. She wasn't from here, and her husband, elderly, had moved here. And so she called them by their names, and had pictures all over the room, and said she had promised her husband that she wouldn't let nothing happen to those dogs. And my God, why didn't somebody tell her, we'll get social services to take care of your dogs for you to have this surgery? And so I thought, well, the nurse was kind of being harsh. Well, maybe they're going to do something for this lady. You know me. And so here comes the cardiac surgery person, doctor. And he literally told her, "Ma'am, this is your fault." I mean, y'all, I'm just like, trying to sit there with my face, taking a deep breath, and my student, y'all, tears flying down my student's face. And I was like, and so he told her, "I'm sorry, ma'am, I cannot do the surgery. You will not live through this surgery. Your ejection fraction was like 20-something%. And so she said, "So you're telling me I'm going to die?" And he said, "We're all going to die." Y'all, I'm just dying. I'm standing in the room with my student just sweating under my pits, and I don't sweat. And so, you know me. Well, sir, can you do some sort of like wound procedure? I wish y'all could have seen him. He looked like the devil himself. No. And I swear, his head circled his body a couple of times. You know what I'm saying? I'm like, oh, okay. And so, yeah. And so he says to me, if they're not too calcified, it might work. And then he was like, who are you? I said, hey, nice to meet you, you know, and told him my name and put my hand out. He didn't even reach up to shake my hand. I was like, whatever. And so when he left, I talked to the patient, and they did go in and do a valvuloplasty where they went in and kind of opened it up and gave her some quality of life. But y'all, that is just like an example of real life to say that we have to get to these patients and replace these valves before their heart function is so bad, and they can't wait. But what do we do as humans? We try to wait until the last possible, you know what I mean? The lady's 80-something years old, but she still has life left. You know what I mean? And that just touched me. I think it was the dog part that really just like tore the heart out of my chest. And you get to love your patients as you're with them. And when they have no one, who at the bedside can help them? You. And that doctor didn't want to mess with that woman, did he? But if the family was there and they were knowledgeable, would they have asked something like that? So be somebody for somebody. And so I'm just saying, I gave you that story to remind you that we've got to do these procedures when the patient's a candidate, not wait until the heart failure, because they're all going to have heart failure, but when the heart failure gets so bad, they're not going to be a candidate. They can't actively take them to surgery. Does that make sense? Because you're going to be like me, and I'm very idealistic, and I got my feelings hurt a lot of times because I didn't understand that not every patient's a candidate for open heart surgery. I thought that you fixed everybody, and it's going to break your heart when you realize that they can't fix everybody. You know what I mean? But there are certain procedures that we can do to give them more quality of life. So do you see this? Untreated equals poor prognosis, and I kind of explained that to you, didn't I? Because there was no fixing this lady, quote. There was just a Band-Aid approach to get her a little bit of extra life. Now these valves up here in your book, and who cares? If you just got to know, that's pig valve. Number A is a pig valve, not stented. Number B is a stented pig valve. Number C is like a man-made type of valve. So who cares? What do you need to know? Tissue valves have to be what?
Replaced
Who would
in 2
need that?
years.
Who would want that? Who would want to have to go back? Did I tell you?
Probably
Young person.
Didn't I tell you
Younger
people who
people.
are going to have a baby maybe and don't want to have to take anticoagulation?
Yeah.
There's one. And then again, what about the old person or somebody who has a bleeding disorder that can't take anticoagulants? They may want a tissue valve, right? So there's other reasons. So there's a reason that there's a couple different flavors. And remember, they're either going to do, there's cadaver valves, and we don't see them much. There's also Singing River, just FYI, and maybe Gulfport are doing valves that they can deploy during the cath lab. They're called Percival, and they're like the Chinese fingers. And what would your concern be? Let me tell you my concern.
It wouldn't go in the right spot.
If it does, what if it don't go in the right spot? And then what if it moves? You know, I want you to sew my sucker down. You know what I'm saying? But anyway, that would be a consideration for someone who couldn't take cracking their chest open, perhaps. So there's a lot more stuff on the market. There's no time for me to explain all the stuff on the market. But don't you think that if your family member needed it, that you would be researching what's on the market, what's the success rate, what are the complications? That's how I want you to be, and that's how I want you to study. Does that make sense to you? Yes. Okay. So, again, before, do you see this little bullet? We want to replace valves before severe what?
Signs and symptoms.
Signs and symptoms and bad heart failure, because they're not going to be candidates. All right. Again, if it's tissue, you're talking about biologic, and they say replace in 15 years, that's old people. Young people, y'all, they can eat up these tissue valves because of all the calcium, and if they're active, do you think they're putting a lot of wear and tear on that new valve? Oh yeah. So these are, cute little things about warfarin and all that. All right. Did y'all see this where it talks about heart valve replacement surgery is like open heart surgery, and how much you would stop their anticoagulants before you crack their chest open? Does that make sense? Yeah. But honestly, you're going to learn all this post-care next level. We will cover care of the traditional cabbage patient, and it is exactly the same. So you don't have to know all this on this slide. Got it? Got it. Good information, but I'm not testing you on that until next semester. All right. Do you need to educate your patient if they have a mechanical valve about anticoagulation? Yes. And if they have a tissue valve, do they need to know that thing's going to poot out on them? Yes. And that they need to follow up? All right. These are really good slides on PAD and PVD. What questions do you have for me about PAD or PVD? Y'all do remember, if someone has PAD, it's the same risk factors as somebody who has CAD. Smoking, eating all that good food, fried chicken. Y'all remember all that? Y'all remember modifiable versus non-modifiable? Okay, so read through these slides and make sure you've got it. You understand we're talking about arterial disease, we're talking about blood flow down. It does occur in stages. Remember, how do you know what stage your patient is in? You ask them what are their signs and symptoms, their clinical manifestations, don't you? And early on, they're going to have what we call intermittent claudication. And we can tell how bad they are according to what they say. Remember this? I can walk halfway to the mailbox, but I have to stop because my legs are cramping. It's kind of like angina of the leg. That's early. Y'all see that? When does claudication occur? Stage 2. If you got a patient who's having pain at rest in their legs and they have PAD, that's later in the disease. You with me? Cyanosis, that rhubarb, all that horrible stuff that occurs is late in the disease. It takes a while for their toenails to get funky and nasty from the disease, right? So y'all getting it? Okay. So with PAD, they're going to have those pale wounds. They're going to look like cookie cutters. Do y'all see how perfectly round that is? Yeah. It's going to be necrotic. Their muscles are going to start dying because they're not using them because it hurts. If you don't use something, do you lose it? Yeah. This shows you ABI, where they take the blood pressure in the arm and the leg, and then they divide the two. If it's less than 1, it's abnormal. If it's like 0.8, that's like moderate, and when it goes lower than that, we're not going to put an Uniboot on them because a lot of them have PAD and PVD, so they have both. They have arterial disease and venous disease, and they'll need an Uniboot, and sometimes we can't put an Uniboot on them because that's going to compress the leg, and is that going to cut circulation off even more?
Yes.
Yes. So again, they may do some other testing. I've not seen this plethysmography or whatever that is used. We do ABI and then we'll do arteriograms, and I've never seen that done, but it is a procedure they can do. Non-surgical management for somebody who has PAD, which means blood won't go down their legs, and how are we going to position their legs to try to get the blood down them? Down or where's the A? Or heart level. You're not going to bring them up. You either keep their legs heart level or down, like the A. All right, so again, if it's not bad, we're going to try to increase their exercise tolerance and give them some drugs to help the blood to be more flexible. The cells get it down the leg, like antiplatelets. If we need to, we can take them to the cath lab or surgery suite and do like an angioplasty like you would in their heart, but we're doing it in their legs. Or they actually have devices now that they can go in there like they do the cath lab and eat the plaque off. It's kind of cool. All right, so there is surgical management for this one. If they have to have bypass surgery or we can do a surgical intervention on their legs, it's the same pre-op teaching. We worry about problems with immobility, so you think we're going to be deep breathing and coughing or do it instead of spirometer? Yes. Do you need to know what their pulses were before so you'll know if they're better after? Yeah. And so, can they get compartment syndrome after surgery from swelling, where it cuts off their circulation, even though we were trying to increase their circulation? So after someone has any kind of bypass surgery, do you think you need to watch their distal circulation?
Yes.
All right, and then assess for infection. Now, if the blood flow cuts completely off to their leg, is that an emergency?
Yes.
So you better get the doctor to them quick. Wake that doctor up in the middle of the night if you have to. Because they'll lose their leg if you don't. Here are the signs and symptoms that circulation has been completely cut off. Do y'all see them? Y'all remember them? Pain, pallor, pulselessness, paresthesia means like weird feeling, needles, and paralysis, and poikilotherapy, which means coldness. They just needed the P's to make 6. Poikilotherapy. That'd be good for Scrabble. Your family will think you're lying. But anyway.
Google it.
Yeah, tell me Google it. All right, so venous insufficiency. The problem with venous insufficiency, and you tell me, is blood return back to the heart. And we want to bring their legs up to get rid of the edema. We don't limit their fluids to get rid of the edema that is caused by this. What do we do to get rid of that edema? Elevate. All right, 5 times a day, 20 minutes. So, because their wounds are open so much, they tend to get infected, so they may need antibiotic. The only surgical management that this patient may have is debridement. And so if it's needed. These are nasty little ulcers. They're irregularly shaped. They're commonly found on the inside of the ankle. And they seep constantly because that's the problem. And they're never going to heal if something's seeping out of it. It's kind of, there's no way it can. There's something leaking out of it all the time. So that's why we do compression and we do an Univoo to treat this area. We have to do a lot of teaching, whether it's a problem of arterial or venous disease. So we teach them to wear the right size shoes, correct size, not too big, not too small. We tell them, don't put yourself in hot water because you can't feel how hot it is. We tell them no lotion between your toes. We tell them to keep their feet clean and dry. We tell them don't you dare clip your toenails. Get somebody else to do it who is certified at doing it, because if you nick them, you're going to have another wound that's seeping a bunch of fluid that can't heal. So we tell them a lot of times to file them if they can't get somewhere for somebody to clip them, and they should clip them straight across, just like the diabetic. We want to keep their skin pliable and moist, but not between the toes. No heating pads, no constricting garments.